So just let me know when you want me to go ahead and get started.
Hello, my name is Freddie. Good morning, everyone. Welcome to TeleShadowing. We are now live on YouTube. Please feel free to ask questions in the chat box and they'll go as we go along and they will be addressed. I am honored to introduce our mentor for today, Dr. Kheshgi. Dr. Kheshgi is an adjunct faculty member at the University of Texas Southern Medical Center. She received a master's in pharmacology from the University of Cincinnati, Ohio, and she completed her rheumatology fellowship from the University of Texas Southern Medical Center. And it is now my honor to request Dr. Kheshgi to begin today's session. Thank you.
Thank you very much. Welcome, everybody. It's a wonderful way to spend a Saturday morning, I guess, getting as much knowledge as you can. And it's going to be short and sweet. So what I'll do is I'll go ahead, in the previous sessions, they would usually ask us to give introduction about our journey to being a rheumatologist, and then go ahead and start the talk. Is that something you all want to leave at the end, or do you want me to kind of go ahead and mention that a little bit at the beginning? Okay, I guess not. So we'll go ahead and get started with the talk here. As you know, I'm a rheumatologist, so we deal with autoimmune disorders, connective tissue diseases. Unfortunately, the word autoimmunity has become a buzzword these days, because the immune system, as we, everything I've learned in the last 20 years, I did not learn in med school, because we have come a whole way forward so far as immunity and autoimmunity go. So the diseases which had little or no treatment, even when I started as a fellow in rheumatology in 1998, I mean, the best medicine we had for rheumatoid arthritis was methotrexate. And if people didn't respond, well, it was steroids or combination medicines and, tons of medicines daily. But since then, we've got like dozens of new medicines which work wonderfully well. And people go into remission with these medications. So there's a whole lot of field out there. However, autoimmune diseases just do not apply to rheumatic autoimmune diseases. Other diseases can be autoimmune, including thyroid diseases, diabetes, what have you. So as rheumatologists, we concentrate on the autoimmune disorders that affect the joints and internal organs. However, we are very specific in the diseases we treat. So I get a lot of referrals generally, to rule out, quote unquote, anything autoimmune, which is a very wide diagnosis. And, it's probably adds more to the, the anxiety of the patient rather than solve anything. So one of the most common referrals which rheumatologists get, which I'm sure a lot of other rheumatologists will attest to that, is the patient's ANA is positive and they have lupus. So they come in and, we usually have a form which asks what they are there for, and they will say, oh, we have been diagnosed with lupus, so we are here to see you for treatment of lupus. So my job today will be to kind of go over a little bit of, what lupus is and how ANA is related. So anything ANA positive, is it really lupus or not, is what, the rheumatologists are there to help you. And I'll kind of walk you through that so you know what to look for. So having said that, let's go ahead and get the next slide here, please. So a 22-year-old woman, she presents to a rheumatology office. I'm just going to do a couple of case presentations of the two extreme ends, and then we'll kind of go into the details later. So 22-year-old woman presents with 3-month history of some fatigue, sleep disorder, missed several days of work. She went to her naturopathic physician who told her that it may be because of her thyroid. Further discussion reports she has redness of the nose and cheeks, which of course the rheumatologist can observe as well. She has achiness in the joints, her wrists and fingers. She has edema bilateral lower extremities and also some unexplained bruising. When you look at her, you can see she has this rash on her face, her nose. She has 3+ pitting edema of the legs. Breath sounds are diminished in both lung bases. And she has some swelling and tenderness of the wrists. So we send out some labs, and lo and behold, her white count, she's very leukopenic, is 1.6, hemoglobin of 9.4, and very thrombocytopenic, platelets of 45. Urine test shows 3+ blood, 3+ protein. There was no leukocyte esterase or nitrites, which would rule out possibility of infection. Creatinine was normal, albumin was 2.2, LFTs, AST was 126, ALT of 140, so they're obviously elevated. ANA is 1 in 1280, speckled and homogeneous pattern. So what do you think this lady has? My guess would be, of course, that this person definitely meets the diagnostic criteria for lupus. And once we go over it, you'll find that. So this is a very classic case of somebody, a young patient, 22-year-old, presenting with arthritis, renal involvement, hematological changes, and a high positive ANA. So they've already met 4 criteria for lupus. So this patient definitely has lupus. So I will go ahead and treat as lupus. So here's another patient, 54-year-old woman, describes a 20-year history of low back pain and fatigue. 4 to 5 hours of interrupted sleep, so non-restful sleep. Trouble losing weight. She says her sister and 4 maternal aunts have been told that they have lupus and it's genetic. BMI is, of course, way up there, so definitely obese, 48.5. Other labs are all normal. ANA is 1 in 40 speckled, so she has a low positive ANA. Does this patient have lupus? And we can circle back to this question at the end of the talk to see what you all think. Okay, let's move on to the next slide. So how common is lupus? It's not very common at all. The prevalence is about 1%, so anywhere between 0.2 to 1.5%, 20 to 150 people affected in 100,000. Prevalence is even lower, about 0.25% diagnosed each year. Age at diagnosis is very important. So young people who show up with classic signs of lupus are more likely to have it. The normal age in which they are most diagnosed is between 16 to 55, about 65%. About 20% will be less than 16, and very small percentage, 15% over the age of 55. There's definitely a female preponderance. Women in childbearing age are much more likely to have lupus. If you could put up that slide. So less than 18, the male to female ratio is 3 to 1. However, in that, age between 18 and 65, the ratio is 15 to 1. So 15 females to 1 male. Greater than 65, again, 8 to 1. So the female are always in preponderance, but especially in the childbearing age between 18 to 65. Of course, 65 is not childbearing, but, in that age range, they're much more likely to be women. It can occur in every population. So African-American, Hispanic, Asian women tend to have the highest risk. And it is more common in urban versus rural areas. Also, I want to make a statement here that not only African-American, Asian women tend to have more, also if it can happen in males, and in African-American males, it tends to be more severe. So that has to be kept in mind. So you get a young male with lupus, be more cognizant of treating them more aggressively. So how do we diagnose lupus? I'm sure most of you have read this criteria from 1997. That's what I was taught when I was a fellow and as a medical student and a resident. And this, there have been multiple variations since then, but so long as you remember this, you will look for the right things. So the 1997 criteria is 4 out of 11 points positive, you probably have lupus. The clinical criteria are oral ulcers, arthritis, like we talked about that young lady with hand involvement, wrist involvement, serositis, which could be either pleuropericarditis or just pleuritis or pericarditis, and neurological symptoms, including, it could be just chronic headaches, it could be seizures, it could be a transverse myelitis. So multiple neurological issues can crop up in people with lupus. Skin findings, which I usually tell my patients to start with. So start because, that's obvious. We don't have to really dig to find out. So the malar rashes, photosensitivity, and discoid lesions. And then, of course, we move on to the labs. So if you have proteinuria greater than 500 or active sediment, you have hematological disorders, which means leukopenia or hemolysis, positive ANA, as well as positive tests for double-stranded DNA, anti-Smith, which are very specific, and antiphospholipid antibodies. Now, remember that ANA is just one criteria. So you have all these other 11 criteria. And if you meet 4 out of these 11, if you have a double-stranded DNA and anti-Smith, both are positive, it's still just one criteria. So 4 out of 11 of these, start with the skin, go on to the joints because those are obvious, then look at them, see if they're having any difficulty breathing, any neurological symptoms, and then go ahead and order the labs. So 2012 SLIC classification criteria, and like I said, there are multiple others. There's a EULAR criteria from 2020, 2021, but most of them are just kind of moving the same criteria around. Some of them are dividing them up into more bullet points where others are not. But so long as you remember those first 11, you're hardly likely to miss lupus. So in the 2012 SLIC criteria, they said 4 out of 17. And the only 2 new things you will see added over here is that they've added alopecia in the clinical criteria, and in the immunological criteria, they have added hypocomplementemia. So C3, C4 will be low. But otherwise, it pretty much stays the same. So in the clinical criteria, you have skin manifestations, you have chronic cutaneous lupus, so they've divided it into 2. Oral ulcers, they have included nasal ulcers in there. There's, of course, alopecia, like I talked about, then arthritis, serositis, renal disease. They have kind of pushed to the clinical criteria, if you have pitting edema with renal disease, neurological criteria, hemolytic anemia, which you could put either in the lab criteria or they've included in the clinical criteria over here, leukopenia, lymphopenia. Now, one thing I want you to be careful about, when they have low WBC, neutropenia is very common in, it's genetic, it's race-based, and we call it cyclic neutropenia. In lupus, you're more likely to have lymphopenia, not neutropenia. Thrombocytopenia, of course. And then they have moved on to the immunologic criteria, which is positive ANA, double-stranded DNA, Smith, antiphospholipid antibodies, hypocomplementemia, which is low C3-4, and then the positive Coombs test, which is the direct antiglobulin test, which shows hemolytic anemia. So the only difference between this criteria and the 1997 criteria that they have put the lab criteria under the clinical criteria, and then they have separated the immunological criteria. They have added non-scarring alopecia, as well as hypocomplementemia in the immunological criteria. So just kind of be cognizant of the fact that they're moving the same things around. And so long as you're looking at all of these, it doesn't matter how many, these criteria are good for, for studies and, for inclusion criteria. But from the standpoint of clinical management of lupus, so long as you look at the skin, so long as you look at the joints, so long as you look at the, pleuropericardial effusions, renal disease, hematological disease, neurological disease, you're covered. And of course, then we have the immunological criteria as well. Let's move on. So this is my patient. So this is an example of, you can see this young lady with just kind of going over the criteria and showing you what the skin manifestations look like. She's got red cheeks, she's got red nose, and she's got a red chin. Now, is it just photosensitivity? She's fairish. Has she just been out in the sun and turned red? Now, the people with lupus, it's not just transient redness of the skin. The rash stays. So it's there whether you're out in the sun or you're not. There's also sparing of the nasolabial fold, which you can see in this patient. So if there's, because just looking at her, you could think it's either just sun sensitivity. Is it just, maybe is it rosacea or is it lupus? In lupus, there's classic sparing of the nasolabial fold. Next slide. Okay. And here is much more common. You see the slide, the gentleman on the right, he has the nasolabial fold, which is totally spared, and there's redness all around. Gentleman on the left. Now, the lower picture, there is some sparing of the nasolabial fold, although there's some redness. So this is the one which will kind of give you grief, and you kind of wonder, is this really lupus or is there some other skin condition here? So this is acute cutaneous lupus erythematosus. So this is discoid lupus. So just before we go on, there are three types of skin lesions. There could be acute cutaneous lupus, which we have just seen. There could be chronic cutaneous lupus, which discoid lupus is an example, or it could be subacute cutaneous lupus, and I'll show you some slides of that too, because to my mind, a picture is worth 1,000 words. If you see these, you're very unlikely to forget. And if you actually see an actual patient after this teleshadowing, you'll always remember it. So these are examples of discoid lupus, which is usually scarring, this depigmentation. It usually involves the face and scalp, although it could affect other organs as well, but this is the usual site. So it's kind of disfiguring as well. This is another example of discoid lupus. As you can see, the scalp is involved, there's depigmentation, there was scarring in the previous one, but also on the left, there's upper arm involvement as well. This is subacute cutaneous lupus. They usually present, they can present on the trunk, on the face, anywhere else. There's kind of like bullet lesions. And I've had patients referred to me by dermatologists, and 3 or 4 dermatologists have seen them and got a different diagnosis from each one of them. Some say it's lupus, others say it's erythema multiforme. And the problem is that the same person can have 2 or 3 other skin conditions as well. So it depends on which one you biopsied and came up with that diagnosis. So you always have to correlate with the clinical condition and see what else the patient has, including their serologies. So acute cutaneous lupus and subacute cutaneous lupus, there is high likelihood of internal organ involvement, whereas with discoid lupus, usually the internal organ involvement is spared. So this is one of my patients actually, and I just wanted to kind of share that, in the previous pictures, we have seen fair-skinned individuals, and it was very obvious what they had. This young lady is a wonderful young lady who had presented to me with full-blown classic lupus. And as you can see the slide on the left, she has those lesions of subacute cutaneous lupus. And after treatment on the right, you see there's complete clearing. So she had about a gram of protein in the urine. She was a pretty sick puppy, but after treatment, as you can see, she has really come along very well. She's now a nurse and getting on with her life. Now, this I really wanted to share, although I don't see much of it. And this is actually, you'll be surprised to learn, and in the last 20 years of practice in rheumatology, this is the first time I saw this. So this is obviously not my patient since I'm an adult rheumatologist, but this is a young patient who brought her daughter with her. And this was her first visit with me. As you can see, this poor baby was born with this rash on her face, perfectly healthy young baby otherwise. And apparently the mom went to 3 dermatologists before she went to a pediatric dermatologist who took about 1 second to diagnose what this was. So this is neonatal lupus. Even though the mothers are asymptomatic, or if they have history of lupus in remission, they can have multiple complications of pregnancy. And this is the least serious of them. The child can be born with this. It just kind of usually resolves itself over several weeks. So this slide I just threw in there since we're talking about skin manifestations of lupus, the one on the left. I can do this. So this, as you see, this is livido reticularis. This is a reticular pattern. Surprisingly, now this you will see in people with lupus as well as with antiphospholipid antibody syndrome. This patient had none. She did not have lupus, and she had an underlying malignancy. So that can cause it as well. You will see this pattern in children when they are cold, which is totally benign. However, in people with lupus, microthrombi in the superficial skin blood vessels can cause livido reticularis. So you have to be cognizant of this. Make sure you examine the skin. This is a patient with mixed connective tissue disorder. As you can see, she has, this is a resolving rhinose. This is just cyanosis. This is a patient, as you can see, these little dots here. She had mixed connective tissue. So she has the cyanosis, but she also has telangiectasia. She had an overlap of lupus with scleroderma. And these are the hands of this young lady I just showed you with subacute cutaneous lupus of the arms. Her fingers look like this. She was a little bit cyanotic, again, resolving rhinose here. So before we move on, what is rhinose phenomenon? So my fingers are cold is not Raynaud's. You'll have a lot of patients come in and claim without that. My fingers feel numb when cold. That's common in some people. When I get cold, my fingers and toes turn white, then purple, and then numb. When I warm them, they get red and swollen and eventually go back to normal. So this is a classic presentation of Raynaud's. As you can see over here, they're white. So she's holding on to a snowball, I guess, trying to hit somebody with it. Blood flow cuts off, low oxygen, so they turn cyanotic. And when they warm them, they become, they turn a little reddish before coming back to normal. And this is thankfully for the, cell phones, I see a lot of pictures because when they come to my office, their hands are totally normal, but they have this picture on their cell phone. So always ask if they have any pictures. They have really helped me, at least, in diagnosing my patients. Okay, so now that we have done the classification criteria for lupus, as we see, ANA is just one criteria. So just having an ANA doesn't mean you have lupus. If you checked everybody, all normal people, what would be the percentage of positive ANA? Low positive, as you can see over here, is almost 20%. 1 in 80, which is still low positive, is almost 15%. Higher positive, 1 in 160, 1 in 320, still a 5 to 10% possibility that patients can have it. In our rheumatology lab, we don't even check at 1 in 80. We call that indeterminate. We usually start checking at 1 in 160. Once it gets to be 1 in 320, you get a little bit more concerned that this patient needs to be worked up further. What is the percentage of ANA in people with lupus? Almost 90%, a high positive, as you see, 1 in 320. And systemic sclerosis, almost up there as well, almost 80%. Sjogren's, pretty high. Rheumatoid arthritis, low positive, 1 in 40, 1 in 80, but 1 in 320, they could have with rheumatoid, especially in people with overlap syndromes. And then fibromyalgia, you see they're negative, but they can also be positive, especially the 1 in 40, 1 in 80. So what is the sensitivity? If you have lupus, there's a high likelihood that your ANA is positive, which we just saw, about a 90%. So the sensitivity of ANA is 99%. The specificity, however, is just 40 to 90%. It could be anywhere between. The positive predictive value is as low as 10%. So if you see a positive ANA, I usually tell my physicians I'm talking to and my students, assume that is not lupus unless they have other symptoms of lupus, because there's just a 10% chance that they have lupus. Most people with ANA will have no autoimmune disorder. Negative predictive value is quite high. So if the ANA is negative, you can almost entirely rule out lupus. I have seen one patient when I started as a fellow who was negative for ANA and had lupus, but he had skin biopsy positive, he had proteinuria, he had renal biopsy positive. So again, if you have all those other, and in the past, they used to use mouse cell lines, we now use human cell lines, so very unlikely. So ANA negative, no lupus unless tons of other clinical criteria, and very, very rare. ANA positive, only 10% chance that they may have lupus, 90% they will not. So that's a high probability that they do not have lupus if they have a low positive ANA. So positive doesn't mean it's lupus, negative means it probably isn't. So what would I tell you to do? Don't worry about staining patterns, subset antibodies. Although these are important in people, for some reason it was on my board exams and it's sneak them in there so, to the chagrin of the students here, but don't worry about that. ANA titers of less than 180 are most likely irrelevant. Greater than 1 in 320, as we just talked about, we start worrying about looking at things. Do not order an ANA to rule out autoimmune disorders. So if they could just come in with arthralgias and, obesity, don't order an ANA unless you actually strongly feel that this could be lupus. So again, total body pain, chronic fatigue, vague somatic symptoms with normal labs, do not order an ANA. So no fishing. You should be pretty strong in your criteria. If they meet criteria, go ahead and order the test for lupus. Otherwise, abstain. Okay, come to this point. So I think we're all clear about, what to look for. You look for skin manifestations, you look for joint manifestations, you look in the chest, you look for pleuropericarditis, you look for in the abdomen, you look for elevated LFTs, renal problems, you look for neurological issues. Then, of course, you check the labs and see what's going on, whether they have hemolytic anemia, proteinuria, and immunologically also. You look for alopecia, Raynaud's, hypocomplementemia. Those are all the things we have talked about. And I know it's a lot to take in one talk, but those are things you can look at yourself. You just have to just remember them. If you divvy it up into, I always tell my students, starting out with skin manifestations, oral manifestations, and then kind of work your way down, the thorax, the abdomen, and neurological, and then go on to the labs. You're probably not going to forget any of these. So you have lupus. What do I do? If you're a severely ill patient, you're either a hospitalist or you're in your primary care office, organ life-threatening disease, what do? By organ-threatening disease, I mean myelitis, transverse myelitis, seizures, optic neuritis, glomerulonephritis, severe anemia, very low platelets, respiratory failure, impending tamponade because of pericarditis. You give them high-dose steroids, so 1 mg per kg per day, which is anywhere between 60 to 100, if they are, not really crashing. Bolus or pulse steroids, which is 1,000 milligrams IV methylprednisolone. And call a rheumatologist stat, whether you have to get them on the phone or whatever, get a consult. They are somewhat ill, moderate arthritis, some muscle weakness, some rashes, mild cytopenias, mildly elevated liver enzymes, a chest x-ray, mild evidence of pleuropericarditis, no evidence of tamponade. You'd go on a lower dose of prednisone, usually between 20 to 40 milligrams per day. Of course, for the skin, you use topical steroids, ultraviolet protection, extremely important. Tell them to lather themselves with sunscreen, both against UVA and UVB, and not the ones that are available over the counter. The 15 or 20 means nothing. They should be at least SPF 45 or higher. Mildly symptomatic with some abnormal labs, mild arthralgias, mild rashes, mild pleuropericardial disease. Consider low-dose prednisone. I almost never go above 20 if needed to make them functional. Topical steroids, of course, UV light protection, like we said. NSAIDs is controversial. I almost never prescribe NSAIDs, especially not over-the-counter ibuprofen. There have been some case reports of aseptic meningitis associated with ibuprofen. So I would stay away from that. However, if it's mild and there's CBC is normal, no history of GI bleeding, they are younger patients, you can probably try something like, meloxicam or some of the other prescription NSAIDs. And I go for prescription because that way you know what they're taking, it's controlled, it's not something they're just kind of self-medicating with. Supportive care, you kind of explain what's going on and where we're going to go from there. Because the more the patients know about the disease, the more likely they are to be compliant. Fatigue is another symptom of lupus, but it is not diagnostic because, chronic fatigue syndrome, fibromyalgia, it's very common. Usually associated with poor sleep hygiene, sleep disorders like sleep apnea, poor lifestyle, depression, certain medications can cause fatigue. Fatigue, of course, will not respond to immunosuppressive treatment unless it is being caused by, inflammation or active disease. So that's what you do, call you're suspecting lupus, call a rheumatologist. In the meantime, supportive care and probably NSAIDs and steroids. So what does a rheumatologist do once we diagnose lupus? Educate the patient as well as other providers is very important. Coordination of additional consultation and diagnostic procedures. So this is extremely important. Lupus is a multi-system disease. It's not confined to the skin or the joints. You have internal organ involvement, you can have lung involvement, you can have cardiac involvement, you can have, of course, kidney involvement. So we definitely need a lot of consultations, depending on what the patient is presenting with, either, a nephrologist or a cardiologist. Because a rheumatologist, as rheumatologists, we don't do kidney biopsies, we don't do echocardiograms. So, we have to refer to these consultants. It's very important to get out to them in a timely manner, not when the patient is crashing. Monitoring screening for disease-related complications. And again, checking their CBC, CMPs, urine on a regular basis. A UA will be abnormal before your creatinine and BUN start rising. So we check them, pretty frequently initially and at least every 3 months afterwards. Management and tapering of steroids. Steroids are wonderful, wonderful medications. They're lifesavers, but they can also come with multiple side effects, including obesity, hypertension, hypercholesterolemia, cataracts, bone loss. So you have to kind of, establish them with disease-modifying agents and taper off steroids. And that is definitely the rheumatologist's realm where they need to work on it. Dosing and monitoring of immunosuppressive agents. That, of course, that's the bottom line. We have to make the patient well, and just treating them with steroids and NSAIDs is not the answer. So we have to put them on immunosuppressive medications. The caveat here is that all of them are slow-acting disease-modifying agents. So they take a while to kick in. So, I've had hospital consults when, somebody's asked me, start them on Plaquenil right away and start them on Cytoxan and we can get them off prednisone. Prednisone, you cannot stop until that medication kicks in, and that may take several weeks. So the cornerstone of treating lupus, that's hydroxychloroquine. I'm sure all of you have heard about this medication. It's an anti-malarial. In the last 2 or 3 years during COVID, it was a very popular medication with politicians, as well as with physicians. Our poor patients with lupus could not obtain it because everybody and their brother was holding on that. It's an anti-malarial. However, it's not an immunosuppressive agent. It's a disease-modifying agent. The exact mechanism, we're still not sure. We think it works through toll-like receptors to modify the immune system. And really, it is the cornerstone for treating lupus. It should be the baseline therapy for all lupus patients. It reduces frequency, severity of flares. It's very helpful in patients with rashes and mild arthritis. The side effects are minimal to none, of course. And like I said, once it was politicized during COVID, there were the haters and the lovers. The haters said, it's going to make your heart stop the minute you start taking it. I've yet to see any cardiac issues with it, although it can cause myositis. It can also cause, abnormalities in EKG. So if you have underlying cardiac disease, a good idea to check with the cardiologist if it's okay to start. However, I've never had to do that. It can cause some skin rashes, especially if you're out in the sun. It can cause hyperpigmentation of the skin. I've seen 2 or 3 patients with that. It can sometimes cause diarrhea. When you start taking it, usually goes away. It can cause pigmentation and deposits on the retina. So we always have to have a baseline eye exam and then make sure that the patient follows up with the ophthalmologist once a year. It's very, very rare. But like I said, it is the cornerstone. Anybody with lupus, unless they're allergic to the medication or have some severe reason why they cannot take Plaquenil, should be on Plaquenil or hydroxychloroquine. So the next kid on the block here is relatively newer, is mycophenolate mofetil, also known as Cellcept. It's used for, more internal organ involvement. It's immunosuppressive and not just immunomodulatory. It's becoming the standard of care for lupus nephritis. Also helps with other conditions as well, including the skin and the joints. GI upset and low blood counts are common. It should not be used if the patient is planning pregnancy. Azathioprine is an older medication and another favorite, especially if younger patients who are planning pregnancy. It's also immunosuppressive. It's useful for rashes, arthritis, cytopenias, as well as neurological disorders. It is used in renal lupus, but only for maintenance and not for induction of remission. It can cause decreased blood counts. So there's a new test, it's called TPMT, which I haven't included here, which we usually test at baseline before starting this medication. If that is low, you're more likely to suffer cytopenias. But anyway, once I start the medication, I check labs every 2 weeks anyway to make sure they are staying normal. That's important. Hepatitis is another thing you need to watch out for. If the patient has gout, which is usually unlikely because young women almost never have gout. However, if you have an unfortunate experience of seeing a young male who has gout and on azathioprine, as well as allopurinol and febuxostat, that is not a good combination. So if they're being treated with allopurinol or febuxostat, try to avoid azathioprine. It's probably safe in pregnancy. That's why it's my go-to medication for young women who are planning on getting pregnant. Methotrexate, another older medication, been around since the 80s, great immunosuppressive agent, works wonderfully well in people with rheumatoid arthritis. In people with lupus, with mainly joint and skin manifestations, it works well, not for renal disease. You have to give, it's once a week dosing. It's a small dose. It's, so a lot of people will ask you about hair loss and stuff. Very, very rare. Some people experience nausea and some mouth sores. You give it with folic acid, which you take every day. Methotrexate dosing it once a week only. I've had a few patients transferred to me from primary care physicians who were taking it every day. That's a no-no. It's a once a week dosing. Pregnancy must be avoided. We actually used to tell our patients that if you get pregnant accidentally on methotrexate, you need to get an abortion, 10% chance of birth defects. So pretty high. So when you put patients on this, make sure they have complete, and especially with the new laws about abortion and stuff, make sure that they are, using strict contraception here. Doesn't mean they can never get pregnant. I mean, if they want to get pregnant, they need to be off methotrexate for at least 3 months before attempting pregnancy. Then we have Cytoxan, which is used a lot. You'll see it in people, especially with renal disease. It's used to maintain remission, induce remission as well as to maintain it, but very toxic medication and mostly supplanted with Celsep now or mycophenolate. We keep going down on that one. So how is it given? Usually it is given to very sick patients in the hospital as IV. Then it is continued on a monthly basis. We usually try to taper off in 4 to 6 months. So if you have severe life-threatening manifestations, renal failure, this is a good drug to start at. Oral, it's usually not recommended because of the increased risk of side effects. And like I said before, it's been mostly replaced with mycophenolate because it's easier to give and less toxicity. Toxicity from Cytoxan would include, of course, infertility, hemorrhagic cystitis, and also long-term risk of bladder cancer. So if they've ever been on Cytoxan and have hematuria, please make sure that they're followed up by the urologist. And it's also teratogenic, so again, can't give it in people who are pregnant, who are planning pregnancy. Other newer kids on the block, and I won't go into detail with this, is belimumab, which is a B-cell inhibitor. It's an IV medication. It's also available as shots. Then we have the anifrolumab. It's used for renal lupus as well as other manifestations, and rituximab, which is also IV. You give that every 6 months. The second one is the interferon inhibitor. The other two are B-cell inhibitors. So again, all modulating the immune response. So I think this is something which I really want to stress on. We've talked about, the diagnostic criteria for lupus, which I think everybody should be familiar with, not to order ANA. And then what is the role of rheumatologists? And that was just to familiarize everybody with the medications that are available and what we can use and what we cannot use. What is your role as a primary care physician is something I'm sure everybody is interested in, and I'm interested in teaching my primary care physicians as well as my students. So good primary care, whatever you would do. Unfortunately, I've noticed over the years that Anytime a patient says any one of my patients goes to the ER or goes to the primary care physician with whatever problem they have, and they mention they have lupus or are on immunosuppressive medications, they are told just go to the rheumatologist. Doesn't matter what they have, whether even if they have a simple infection or hypercholesterolemia or anything else. I had a poor patient with psoriatic arthritis on Humira who spent a night in the ER with an ear infection and was released on hydrocodone and told to go to see her rheumatologist in the morning. So it was up to the rheumatologist to prescribe antibiotics, which is really not good patient care. So age-appropriate vaccinations. Just remember, if patients are on immunosuppressive medications, the only things you want to avoid are live vaccines. Anything else is, they need to get vaccinations just like anybody else. So the live zoster vaccine was a no-no, but now we have the killed one, so they can use that, the inactivated one. Age-appropriate cancer screening. Again, anybody with immunological disorders, higher risk of malignancies, higher risk of infections, that. So age-appropriate cancer screening is very important, and that just includes, the regular mammograms, breast exams, pap smears because they're young women. If they're older women, of course, colonoscopy, and then, of course, hematological malignancies, any lumps or bumps which they're not sure of, need to be investigated. Osteoporosis screening, because these patients are often on steroids, so be very cognizant of that. Make sure they are getting enough, vitamin D screening is very important as well. So, make sure they're getting enough calcium in their diet and check their vitamin D. Contraception. Avoid estrogens. Again, there you'll find if you start investigating, there are various papers for and against, but by and large, we have seen the estrogens can increase your risk of blood clots. People with lupus and antiphospholipid antibody have increased risk of blood clots, so I try to avoid estrogen if I can, unless it's absolutely necessary for whatever reason. Modification of risk factors. People with lupus, higher risk of cardiac problems. So make sure hypertension is well controlled, make sure their cholesterol is checked periodically, smoking cessation. So just common sense things which you would tell your normal patients. Same applies to lupus. Their risk is higher. So closer monitoring and closer, paying attention to what could go wrong. Mental health care, anxiety and depression, as in any other chronic illness, it's common in people with lupus. So that needs to be addressed, whether it's counseling, exercise, or actual prescription medications. So that's a quote from another talk. Lupus inhibits other doctors' brain function. And that's just the scare of lupus, which I try to take away in my talks. It's a very treatable disease. It's a bad disease. But if it's treatable, like, I showed you my young patient who had come in with subacute cutaneous lupus and, with all those skin rashes, proteinuria, she's doing wonderfully well. The first time I saw her, she was a college student. Now she's a nurse and she's working and she has absolutely no symptoms, but she's following closely with myself as well as her nephrologist and her primary care physician. So just because they have lupus doesn't mean they will not be able to live a normal life. Pregnancy is definitely possible, may have some worse outcomes, so you have to monitor them carefully. But so long as they're in remission, I would not definitely recommend pregnancy if they are not in remission, but 3 months into remission, they can certainly get pregnant and they have to be monitored closely. Now, they had a whole bunch of slides with pregnancy, but I removed them just because to cut the talk short. So I think that should do it. I'm ready for any questions if anybody has any.
All right, thank you so much, Dr. Kheshgi. We really enjoyed this insightful session, and I'll now begin our Q&A session. So my name is Amna, and I'm an undergraduate student at the University of Maryland, majoring in neurobiology and physiology. So our first question we have is, since rheumatology is a field that deals with autoimmune disease, how do you differentiate between a rheumatologist and an immunologist?
Okay. Yeah, so a rheumatologist usually deals with connective tissue diseases and autoimmune diseases that also involve the joints. And that includes things like lupus, rheumatoid arthritis, psoriatic arthritis, others. Immunologist deals with immune dysfunction. And so, there's a lot of overlap between immunologists, rheumatologists, allergists. But, again, we deal with different diseases. I don't think immunologists would be comfortable dealing with lupus or other rheumatological diseases.
Got it. That makes sense. Thank you. Our next question is, what is the difference between leukocytoclastic vasculitis and systemic lupus? As I know, clinically, they're very similar. So how are biopsy results used to rule out differentials or other ways to rule out the differentials between the two?
I'm sorry, could you repeat that again? Between systemic lupus and what else?
Leukocytoclastic vasculitis.
Oh, okay. So leukocytoclastic vasculitis is usually self-limited. It usually involves the lower extremities. There's no other systemic signs. With leukocytoclastic vasculitis, again, anytime you're looking at vasculitis, you could have, abdominal symptoms. There's history of hepatitis, polyarteritis nodosa, what have you. So that's a whole different differential. Systemic lupus, if you stick to the diagnostic criteria, the biopsy reports can look very similar in some of these as well. But that's a whole different talk. They could look very similar, but you have to use your clinical acumen and the clinical criteria to differentiate between the two.
Understood. So follow-up question regarding leukocytoclastic vasculitis. How would you say that, have you ever noticed like links between stress and symptoms of leukocytoclastic vasculitis, or is it just like gravity-based as it happens in lower extremities?
No, it's not usually gravity-based. Leukocytoclastic. And I tell all my patients, in the immune system and the psyche are very closely related. So stress will make everything worse. I've had patients with psoriatic arthritis, the psoriasis flares up with stress. I've had patients with lupus who flare up with stress. So stress is not good. And that's why I always recommend, regular exercise because, kind of relieves stress. And, like we said in that last slide there, that it's important to control anxiety and depression because that'll make things worse. Leukocytoclastic vasculitis can be idiopathic a lot of time. It can be associated with infections. Stress will definitely make it worse. I don't think it's causing it, but it can certainly make it worse.
Got it. Thank you. So as you mentioned in your talk that Plaquenil or hydroxychloroquine is indicated in systemic lupus. So what are the indications for Plaquenil in leukocytoclastic vasculitis? And what are your thoughts on symptomatic relief of the disease with steroids such as prednisone, like you mentioned?
So I'm not sure. Why are we talking leukocytoclastic vasculitis?
We just had a few focus on that, but we can move on to rheumatoid arthritis if you would prefer.
Okay, no, that's fine. So leukocytoclastic vasculitis is usually self-limited. It goes away. So far as Plaquenil is concerned, so it's indicated for a lot of skin manifestations of different diseases. We use it in people with. So if leukocytoclastic keeps coming back and it's not going away and it's idiopathic and there's no other reason that you can control, then we usually do use other medications, including colchicine. We can use hydroxychloroquine. So those are things we can use, but depends on, how they're presenting as and, what's the reason for it.
Got it. Thank you so much.
We use it in skin manifestations for sarcoidosis. And there are various other skin conditions we can use hydroxychloroquine for.
Got it. Thank you. So now a few more questions. They're related to rheumatoid arthritis. So what are the specific risk factors associated with rheumatoid arthritis in adults? And is there any way to prevent it or to know if one is more likely to develop it in the future?
So rheumatoid, the bottom line is we don't know what causes it, right? So that's $1 million question. We definitely know that it could be a case of molecular mimicry, which means that, there's something in the environment that triggers. So the normal function of the immune system is, anything from outside, whether it's an infection, whether it's a cancer cell, whatever mutation is there, it tries to get rid of it. But it has self-tolerance. It doesn't attack your own body. What happens in autoimmune disease is that it starts attacking your own body. Once it does that, you have to, of course, modulate it and kind of calm it down so it stops doing that. What causes it, we don't know. We think it may be, so there are quacks out there who say, oh, it's an infection and start treating. We do treat rheumatoid arthritis with doxycycline, but that's because it's a metalloproteinase inhibitor. So we're using it for a different reason, not to treat an infection. So we don't know. Prevention, like I said, is if you have a family history, you are more likely to get it, although it's not 100%. And prevention, like with anything else, good lifestyle, exercise, smoking cessation, anything that applies to anybody else for a healthy lifestyle is what I would recommend for people with lupus and rheumatoid arthritis.
Thank you. That was very insightful because I recently took a course this summer. It was on cellular mechanisms of different diseases, and my final project was on rheumatoid arthritis. So no matter how much I would look up what's the cause of rheumatoid arthritis, nothing would show up. So thank you.
There isn't. Yeah, no. I'm sure maybe in the next 50 years or 10, who knows, but at this point, no, we do not know what causes it.
Yeah.
I mean, there's definitely a genetic predisposition. So you see it but it's incomplete penetrance. So you don't see it, it's not a given that if mom has it, daughter will have it, or dad has it, or son will have it. I mean, we have some others like ankylosing spondylitis and stuff. There's HLA-B27 association with that. But again, 8% of people have the gene, only 1% ever develop the disease. So what is it that triggered it in the 1% who develop the disease? We don't know.
Exactly. So our next question is also on rheumatoid arthritis. So what are some of the primary common characteristics of the prescribed treatment plans for patients with rheumatoid diseases in general?
There's no general treatment. Is that? I'm not sure I get the question clearly. Saying just a general treatment for rheumatological diseases?
Primarily like characteristics, like things that are in common between. So like there's like steroids, and then there's symptomatic relief, stuff like that.
Right. So like we just talked about, there's no it's not a one size fits all. So rheumatology is really the art of practicing medicine. It's not an exact science. 2 and 2 is not 4. 2 and 2 could be 10, or 2 and 2 could be 0. So people can have very high antibodies and have no disease, and have no antibodies. 30% of people with rheumatoid arthritis don't have rheumatoid factor or anti-CCP, and they still have rheumatoid arthritis. So it's very individualized. It depends. So again, immunosuppression is, of course, the baseline, because the problem is not, of course, you will treat somebody presents with joint pain and swelling, you've got to get that down. But the long-term treatment is immunosuppression, because if you just keep treating the symptoms and don't treat the disease, it's just going to cause multiple deformities, which was the case in the previous, before we had all this understanding of immunology. So baseline treatment, like I said, control of anxiety and depression, good lifestyle, NSAIDs, maybe if it's very mild. Steroids are very good, and they're the mainstay of therapy to start with in most of our diseases, because not only are they immunosuppressive, they're also very strong anti-inflammatory. So that's why, you use it in people with asthma for control, because it controls inflammation in the respiratory areas. So, that's what is important.
Got it. Thank you. Yeah, that's why rheumatology is very interesting, because it's definitely a case-by-case focused, and there isn't like one size fits all, as you mentioned. So we have a question in the chat. So from Sam, it says, you said to avoid giving estrogen to pregnant patients. So does the same thing apply to breastfeeding new mothers, like with mothers who have lupus? Does that apply to their breastfeeding routine?
No, I did not say avoid estrogen in pregnant patients. I said avoid patients in people with lupus.
Understood. Okay.
Right.
All right. Thank you. We have just 3 more questions. So do you have any advice or further resources for students who are interested in learning more about pursuing a career in rheumatology?
So I think the best thing to do is, when they are rotating, so this teleshadowing session should help. The resources, Annals of Internal Medicine, JAMA, there's so many other, out there they can look at, and just depends on their interest. I mean, rheumatology, there was a question on there, why did I decide to be a rheumatologist? And it's quite funny. That was the last thing on my mind when I came into internal medicine to be a rheumatologist. And my first choice would have been probably allergy immunology, something I was really interested in. And then I was doing my PhD coursework there in Cincinnati. And, I took a course in immunology, and it was just so very interesting. Nothing, we didn't even have books keeping up with what the information coming out. So our professors would just bring out these, these journal articles and distribute them for what's new in immunology. And so that's pretty much, and the reason I became a rheumatologist when I applied, and, so I applied in a rheumatology program here. And, I got in, and so I could have gotten into a combined program for allergy, immunology, and rheumatology, I think, which is offered at Galveston here in Texas. But that I would have had to wait a year. This program, which is a wonderful program at UT Southwestern Medical Center, so I have never looked back. I think it's the best decision of my life. It's a very cerebral one. So if you're more hands-on, more in lines of what surgeons do, this is not the best specialty for you. But if you're more pragmatic and if you want to learn more about things and think about it and more cerebral, then this is definitely a good field to be in.
That's really interesting. I've definitely heard a lot of stories about how just one moment or one conversation with a mentor can change your whole career path. So for our last question, how do you manage your work-life balance in the field of rheumatology?
Work-life balance, that's always a tough one. But rheumatologists, it tends to be easier because you have time to think. The acute management is usually with, steroids, heaven forbid the patient is hospitalized. They can be pretty sick, but you have a lot of support. There are the physicians involved. And so long as you get your patients to be compliant, and that's the major thing, it's usually, it's an outpatient practice mostly. And the hours you can fix. So I think, and you just have to, it's not as well paying as, so I've been asked that question before. I mean, what is where I'll get paid the most? And my answer always to that is, it depends what you're interested in, because if you're getting paid a lot, but you're miserable, that's not the field to go into. So, and you can manage your hours. You can, I always, when my kids were little, I still do that. I just work straight through 8 to 2. I don't take any lunch break. So my 6 hours of scheduled patient time is done. I still don't get done with charting and stuff till about 4 or 5. But the good thing is that I can take that home. If I need to be somewhere at 2, if I need to be somewhere at 3, if my kids are coming home at 4, I can be there for them. And then just, of course, it's hard on me because then I have to work till 10 at night to complete my charts, but at least it gives you that flexibility. So I think that helps. So you just have to, you have to be very sure of what you want, because if you don't love what you're doing, the work-life balance is very difficult.
Yeah, definitely. So
you have to love what you're doing, right? It has to be your passion, and then everything else just kind of falls into place.
Exactly. So, all right. Thank you so much, Dr. Kheshgi. Those are all the questions we had for today. So we'd like everyone to give a thank you in the chat box for this incredible session.
Thank you very much. I hope you all learned a lot.
Thank you. All right. Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for the session is now live, and you'll need a 70% or higher to pass and receive certification. And that link is being sent in the chat now. Now on to our next session dates. These dates will also be posted on our social media outlets, so be sure to follow us at TeleShadowing. And so August is the month of rheumatology, and so we'd like you all to tune into our next session next Saturday, August 15, 10 a.m. Eastern Standard Time. August 12th, sorry, my mistake. August 12th at 10 a.m. Eastern Standard Time for another rheumatology session in Rheumatology Month. Thank you so much, everyone, for attending today's session.